Right, so acute decompensated heart failure management on the floor is important to identify hemodynamic profile and triage accordingly. So the warm and cold versus cold and dry versus wet. So it's essentially adequate versus inadequate tissue perfusion. And this can be essentially seen by altered mental status, lactic acid, cool extremities, and narrower pulse pressure. And then dry versus wet is essentially a surrogate marker of pulmonary capillary wedge pressure and presence versus absence of congestion. And this can be seen with JVD, crackles, pleural effusion, ascites, lower extremity edema, and interstitial alveolar edema on chest x-ray. So essentially, patient who has cold and wet, these are generally patients in cardiogenic shock and should be in the intensive care unit. And patients who are usually warm and wet, this is your classic inpatient decompensated heart failure that has good perfusion, however is congested and has elevated likely pulmonary capillary wedge pressure. So always important to do a full and thorough physical exam and evaluate for signs of pulmonary congestion and pulmonary edema. It's important to know that sometimes can be absent on chest x-ray in chronic heart failure, especially in younger patients due to lymphatic compensation. And 80% of decompensated heart failure patients with reduced rejection fraction and nearly all decompensated HFpEF patients will be warm and wet. So what I described previously with good tissue perfusion, however, with fluid overload. Sorry, next talk we'll be talking about the history, identifying precipitants, and the early acute management of inpatient decompensated heart failure, as well as pre-discharge optimization.